Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach for Step 1 and Step 2. Today we'll be reviewing a Step 2 CK question in pediatrics. So let's start by reading the stem. A 10-month-old boy is brought to the emergency department with 1 day of fever, irritability, and poor feeding. Temperature is 40 degrees Celsius, heart rate is 190, respiratory rate is 60, and blood pressure is 60/30. Extremities are warm, pulses are bounding, capillary refill is 4 seconds, and mucous membranes are dry. Blood cultures grow staph aureus. Which of the following is the most likely mechanism for these findings? So I'd like you to pause the video and try to work through this question on your own first. So welcome back. Let's work through this question together. So the first thing you should do when you approach a question is to read the very last sentence. So read the question itself and try to understand what the question is asking you to do. So which of the following is the most likely mechanism for these findings? So this tells you that this is going to be a pathophysiology question. Then you should briefly glance at the answer choices. You don't need to read every single one in detail. I just want you to glance at the words, and by doing this, you are realizing that all the answer choices are going to be pathophysiology mechanisms, right? So we're seeing all of these without even reading them in detail are relating to pathophysiology. So this is going to frame how we approach the question stem. Remember that board's questions are two-part questions. The first part is where you have to identify the diagnosis, and then the second part, you actually have to answer a question about the diagnosis, and that might be a question about the pathophysiology, the diagnostic workup, or treatment or management of some sort. And most questions follow this pattern. So here we're going to have to identify the diagnosis in the stem and then answer a pathophysiology question about the diagnosis. So let's read from the top. A 10-month-old boy is brought to the emergency department with 1 day of fever, irritability, and poor feeding. So let's start by looking at these elements. In pediatrics, especially in questions about neonates or babies, we are going to have to recognize non-specific vague symptoms that indicate that the baby is not well or is sick. Remember that infants cannot really communicate with us what's bothering them. They can't tell us that their stomach hurts or that they have a headache. What they can communicate with us is their feeding habits, their crying, their fussiness. So whenever you see these descriptions of infants, such as irritability, fussiness, poor feeding, inconsolability, lethargy, somnolence, these are all non-specific symptoms that should clue us in that the baby is not feeling well or that the baby is sick. So look for these types of descriptors in pediatrics questions about infants because you won't necessarily have a very specific description of their symptoms because they can't communicate that to us. So let's keep reading. Temperature is 40 degrees Celsius, heart rate is 190, respiratory rate is 60, and blood pressure is 60/30. So these vital signs look very different than the vital signs we would see for adults. So let's briefly take a moment to review vital signs in infants. So in pediatrics, the vital signs are not going to follow the same guidelines that we use in adults. So in adolescence, you can pretty much use the same ranges that you're familiar with for adults, but in younger children, especially in infants, the vital signs will be very different. So the younger the child is, the higher the heart rate tends to be, the higher the respiratory rate tends to be, and the lower the blood pressure tends to be. So in questions about infants, and here when I say infant, I'm referring roughly to children that are about 0 to 1 year of age, so less than 1 year of age. And in this time frame, you can use these rules of thumb to remember what the normal vital signs are in infants. So heart rates will be more elevated the younger the child is, but in general, you can use 160 as a rule of thumb. If it's greater than 160, we're in the tachycardia range. Similarly, For the respiratory rate, it's a little bit more variable, but infants less than 1 year of age, we can use 50 as a rule of thumb. If it's above 50, we're in the tachypnea range. And then the opposite is true for the blood pressure. The blood pressure of children and infants is going to be lower than that of adults. So there's a really neat rule of thumb that you can use for blood pressure, and this actually applies for children aged up to 10 years. Up to 10 years. So not just in infants, you can actually use this rule of thumb in other older pediatric patients. And this rule of thumb says that the lower limit of normal for the systolic blood pressure should be about 70 plus 2 times the age in years. So for our patient who was about 1 year old, we can use this rule of thumb and determine that the lower limit of normal for the systolic blood pressure would be about 70 plus 2 times 1, so about 72 would be the lower limit of normal for the systolic blood pressure. So if you remember these 3 rules of thumb, you'll be able to tackle vital sign questions or be able to interpret vital signs in any pediatrics question referring to infants. So let's look back at our question stem. So if we look at our vital signs, obviously 40 degrees Celsius, we have a fever here. The heart rate is 190, which is greater than 160, so we have tachycardia. The respiratory rate is 60, which is above our limit of 50, so we have tachypnea, and the blood pressure is 60 over 30. So we had used 72 as our lower limit of normal, so 60 is much lower than that. So this blood pressure is low. So let's keep reading. Extremities are warm, pulses are bounding, and capillary refill is 4 seconds, and mucous membranes are dry. So the capillary refill time is prolonged. 4 seconds is too long. It should be less than about 2 seconds. And mucous membranes are dry, which is giving us a sense of the patient's hydration status, and he's showing us signs of being dehydrated. Blood cultures grow staph aureus. So this is telling us that this patient is bacteremic. So before moving on to the answer choices, let's take a moment to synthesize what's going on here. So this is the step where you look at the items that you have highlighted in the question stem, you put them together, you synthesize them, and you take a stab at what the underlying diagnosis or illness script is. And this is important because you need to be able to identify the diagnosis before you can answer the next question about it, right? Remember our 2-step questions? First step, identify the diagnosis, then answer a specific question about it. So this step should only take you a few seconds, but it's crucial to not getting distracted when you look at the answer choices. So putting these pieces together, we have a patient, a young infant, 10-month-old, with fever, irritability, tachycardia, tachypnea, and hypotension, with physical exam findings notable for warm extremities, bounding pulses, delayed cap refill, signs of dehydration on exam, and bacteremia. So putting all these pieces together, this presentation is concerning for septic shock. So let's talk a little bit about septic shock. Moving forward here. So septic shock has a very specific definition, and it's important to understand this definition and what are the pieces that are crucial to define septic shock. So septic shock, the definition is that the patient must meet 2 out of 4 SIRS criteria and must have a suspected or proven source of infection, and finally must have signs of cardiovascular dysfunction. So let's see if our patient meets these criteria. So what are the SIRS criteria? Well, there are fever, tachycardia, tachypnea, and a leukocytosis. In this question, we didn't have a white blood cell count, so we can't really speak to that. But he already meets more than 2 out of the 4 criteria, which is what you need. So he has fever, tachycardia, and tachypnea. So he meets SIRS criteria. Well, does he meet the criteria of having a suspected or proven source of infection? Well, remember that he was bacteremic with Staph aureus growing in his blood cultures. So he also meets this criteria. And finally, does he have signs of cardiovascular dysfunction? And in this patient, we have signs of poor perfusion, including the delayed capillary refill time, and we have the patient's blood pressure, which is very hypotensive. So he meets this criteria as well. He has hypotension and signs of poor perfusion. So he meets this criteria. So our patient is in septic shock. And the physical exam findings could also clue us in to this, in addition to the vital sign abnormalities and the source of infection. So these findings include the warm extremities, bounding pulses, the wide pulse pressure, and the prolonged capillary refill time. So any of these findings would be concerning for septic shock in combination with these criteria that we discussed up here, especially the vital sign changes and the source of infection. So you should be able to recognize this presentation. You should be able to recognize the vital sign abnormalities in combination with the signs of poor perfusion, physical exam findings, and the source of infection. This constellation should raise a big red flag for septic shock. So next, let's talk a little bit more about the pathophysiology, because these physical exam findings are a direct manifestation of the underlying pathophysiology, and this is a question about mechanisms. So taking a step back, septic shock occurs when you have an infection, and it can be a local infection. It can be localized to the bladder, it can be localized to the lungs, it can be in the blood, it can be anywhere. It doesn't have to be a widespread infection, but it can be a local infection. But this local infection leads to widespread systemic inflammation in the entire body. So this is the big picture principle of what occurs in septic shock. So infection leading to widespread systemic inflammation. And remember that there are different types of shock. There's distributive shock, cardiogenic shock, obstructive shock, and hypovolemic shock. And septic shock falls under the category of distributive shock. So distributive shock is characterized by increased vascular permeability in combination with decreased systemic vascular resistance due to peripheral vasodilation. And this is going to be manifested on our physical exam by warm extremities, for example. So distributive shock characterized by increased vascular permeability and decreased systemic vascular resistance. And this is really going to be the main disturbance in distributive shock. Remember, each of the types of shock has one primary disturbance, and then the other physiologic principles go hand in hand with that primary disturbance. But in distributive shock, the primary disturbance is going to be decreased systemic vascular resistance. This leads to the patient's inability to maintain systemic pressures. So this leads to hypotension, and more importantly, it leads to low mean arterial pressures. So in order to maintain perfusion, the body is going to try to compensate for these low pressures, for this low mean arterial pressure, by increasing cardiac output. So increased cardiac output is a compensatory mechanism for the low mean arterial pressure that is happening in the setting of distributive shock. And this increased cardiac output leads to a hyperdynamic circulation. And so this is going to be manifested on exam by bounding pulses and tachycardia, which is the heart's response, compensatory response to try to maintain perfusion to tissues in the body. Because over time, these mechanisms are going to lead to inadequate tissue perfusion in the end organs. So over time, we're going to get poor tissue perfusion, and this can manifest in multiple ways. One of the important ways this can manifest on laboratory findings is going to be by a lactic acidosis. So you might have an elevated lactate on a blood gas, and you might also see an anion gap metabolic acidosis. Remember, the L here stands for your L in mud piles. So lactic acidosis is an important cause of an anion gap metabolic acidosis. So be sure to calculate your anion gap if there's a question about a blood gas in the setting of septic shock or something relating to septic shock. You always want to keep a close eye on your acid-base disturbances. Another way that this manifests is on the exam with a prolonged capillary refill, which is due to the poor tissue perfusion. So these principles are the core pathophysiology principles that are important to remember and to understand when we're talking about distributive shock and specifically septic shock. So now that we understand the clinical presentation and the pathophysiology, let's take a look at the answer choices again. So let's take these one by one. First, I want to start by knocking out some of the distractors that are here just to frighten you. So in these pathophysiology questions, there are often going to be a number of mechanisms that have nothing to do with the diagnosis at hand or with the issue at hand. So here we can look at answer choice A, increased hydrostatic pressure. So this is certainly an important pathophysiologic mechanism, but it's not that relevant in the case of septic shock. Remember that increased hydrostatic pressure can lead to peripheral edema, but it's not particularly relevant to septic shock. So let's cross that one off. It's just a distractor. Next, let's take a look at answer choice F, decreased oncotic pressure. This is another distractor that also leads to peripheral edema, but it doesn't have much to do with septic shock. So let's cross that one off. Next, we're left with answer choices B, C, D, and E. So let's take a look at these more closely. So B, decreased systemic vascular resistance. Could be right. Let's look at the next ones. Let's leave that one as is for now. Increased pulmonary vascular resistance. So this can lead to a different type of shock. Do you know which one? So this could be seen in the setting of a massive PE, where you would get, over time, you can get hypoxic vasoconstriction, and this hypoxic vasoconstriction can lead to increased pulmonary vascular resistance. And this resistance essentially leads to obstruction of blood flowing from the right ventricle through the lungs into the left ventricle. So answer C may be correct in the setting of PE causing obstructive shock. Not all types of obstructive shock, but specifically in the case of PE, but it's definitely not relevant here because we're talking about septic shock. So we can cross that one off. Then let's look at answer choice D, decreased cardiac output. So this is the primary disturbance in a different type of shock. Do you know which one? It's cardiogenic shock. So in cardiogenic shock, decreased cardiac output is the primary disturbance. So remember that in septic shock, we actually get increased cardiac output, which is a compensatory response for the low mean arterial pressure, the poor pressure, and the poor tissue perfusion. So the heart tries to compensate by increasing cardiac output. However, in cardiogenic shock, because this is a primary disturbance, it's actually going to be decreased. So this is relevant for a different type of shock, cardiogenic. It's not relevant here. It would be the opposite. It would be increased. And then lastly, answer choice E, increased pulmonary capillary wedge pressure. So remember that your wedge pressure approximates the pressure in the left atrium. And the pressure in the left atrium might be elevated, for example, in the setting of a left ventricle MI or heart failure, where your blood can't pump forward into the systemic circulation. So it actually backs up into the left atrium and then into the lungs, most likely. So when your wedge pressure is elevated, it tells us that there's a problem going on with the heart itself in the left ventricle, and that the left ventricle is not able to pump that blood forward, and so it backs up into the left atrium and it elevates the pressures in the left atrium. So again, answer choice E would be correct potentially in the setting of cardiogenic shock, but it's not relevant in the setting of septic shock. In septic shock, this would not be elevated. This pressure would not be elevated because there's no problem with the pump itself. So I'm going to put cardiogenic here. And just as a test taking tip, It's also wrong because you can never have two correct answers. So D and E are both referring to cardiogenic shock. So it wouldn't be possible for them to both be correct. So as a test taking strategy for other questions, you can, if you're in doubt, you can always rule out two answer choices that are both correct. So that leaves us with answer choice B. And since we've already learned that the primary disturbance in septic shock is decreased systemic vascular resistance from that peripheral vasodilation and the increased capillary permeability, we can identify answer choice B as being correct. We ruled out all the other answer choices and we learned about the pathophysiology and septic shock, so we were able to identify this as the correct answer. So that wraps up our question of the week, and thanks for listening.